Everybody, and first of all I'd like to extend my sincere thanks to Badar for the invitation to be part of this group of faculty who've come here today. It all started over a breakfast we had together back in Budapest, and it sort of grew and got legs from there. And I said to Badar, you know what, I've never been to the Middle East, and it seems absolutely crazy that I've never been here. I've traveled so many times back and forth between Melbourne, Australia and Ireland, because I'm not Australian. Well, I am Australian, I have a passport, but I'm actually Irish. Born and raised in Ireland, and I come from a big family of 8 children, and I go back every year to see my family and my children growing up. We went back every year. We flew through with Etihad Airways through Abu Dhabi. Emirates was always too expensive for us, and Qatar Airlines even more expensive. So Badar treated me to my first flight flying with Qatar Airways, and I took out my phone and took a video clip of the seat in the aircraft and sent it back to my children. They said, wow. And said, Dad, why didn't you go there before? And I said, well, honestly, I've got no real answer why, but I hope you'll be coming back here again someday soon. But I guess what's a standout about coming here is the warmth of the people and everybody that I have met here. The IT team today at Badar's clinic, his staff, he's got a unique chemistry in his staff at his rooms. The staff at the hotel here and everybody I have met, I got to say it's a completely new dimension that's opened my eyes, and I have a great regret that I've not been here before. You probably noticed that when I scan and I teach that I talk far too fast, and I'm going to try and go a little bit slower. I might go a little bit over time, but maybe I'll slow down a little bit, because there's so much to say, I guess, about first trimester. And so much has changed in recent years, and the ISUA guideline 2023 is a stunning guideline because it's transformational in what we do in day-to-day practice and what the expectations are. And I know there are different levels of experience today in the audience. There are those who are very junior in their training, and there are those who are very senior in their training, and I'll try and cover from basic to more advanced. The talk is divided into these following sections. Just to give a background, an overview, an introduction, I will mention about the ISUA guideline, and of course the biometry measuring nuchal translucency, focusing on anomalies and across all organ systems. But you know, here I'm saying in the Middle East, giving a talk in first trimester, and I say, you know, people say to me, it's not possible to do an anatomy scan and look at all of these in a baby that measures the length of a credit card. Actually, it's 1 centimeter shorter than the length of a credit card. You can't see it, it's too small. It's actually the same thing that people in Australia say. It's not possible. I can't do it. Maybe you can, but I can't do it. And I much prefer wait to 20 weeks because, you know, I'm going to be able to pick up all these problems at 20 weeks of gestation. I'm hoping maybe in a sense that by the end of our 2 days, that for those of you who hold that view, that maybe I might change that view around a little bit, because I think it is possible. In fact, most of the major structural problems, I think, are identifiable in the first trimester. And in the new world of exome sequencing, I think it becomes increasingly important that we make diagnosis earlier. But I think any pregnant woman wants to know about problems, whatever decisions they choose to make. They want to know about them early, so there's longer preparation, optimization of where to deliver, and optimization of surgical treatment after birth. But the single most important take-home message that I will have in the center of this is having a protocol and a systematic approach to what we do. And in a sense, that's the key to success in the first trimester. And I just want to pass on some clues as to how to make that systematic approach easy and practical going forward. And I think why is diagnosis important? Because that's what a mother, I think, wants to know, or most women want to know, what the problems are and what is the testing that's available. And for many of these, genetic testing is the next step in which many women want. And it's not just doing a chromosome count anymore. You know, we're on to looking at chromosomal microarray, offering microdeletions and duplications, and we're in the whole new world of exome sequencing. And that's, you know, a big change, because we now recognize that a very high proportion of babies with structural abnormality, we proceed with exome sequencing. And I'll give you a stunning statistic for Melbourne, where I work, is that the average gestation in which we offer exome sequencing and get a result in Australia is the order of 28 to 30 weeks of gestation. And that's quite late in the pregnancy. Whereas if you do a first trimester diagnosis and offer exome sequencing, you will have the result by 17 weeks. And that adds additional momentum to making earlier diagnosis. So you used to go back to the basics of what a first trimester scan, what it is that we do in a first trimester scan. I'll just start my stopwatch. We assess gestational age, and that is by crown rump length. I meant this morning. I talked about doing all the other biometry, but it's crown rump length in which we use to date the pregnancy. We do an aneuploidy risk assessment. Many countries continue with first trimester combined screening. Talk about that maybe in Q&A. And then we do an anatomical assessment and then assess for adverse pregnancy outcome, in particular preeclampsia. So they're the four major groups that we look at in first trimester screening. So how do we do it? The patient drinks 2 glasses of water half an hour before the examination. They sign a consent form, and on that consent form it reads that the detection rate of fetal malformation is higher at the transabdominal and transvaginal examination, and the published literature supports that. 97% of our population say, yes, I would like a TV and a TA examination. We do a transabdominal scan, go as far as we can. We do the biometry transabdominally, do as much as the anatomy as possible. Patient goes outside, empties her bladder, and then we proceed with an endovaginal scan. We allocate for that as sort of a 30-minute, although recently we've increased it. These are the ISRO guidelines 2023, which I say have been transformational, and this is the basic guideline. There's a minimum requirement, but this is what you're here today to learn about. In a sense, it's more the detailed scan in the first trimester. I ask you a question. If you look at that image on the left-hand side, it shows you the number of images that you are expected to take as part of a detailed first trimester scan, ISRO Guideline 2023. If you look at the ISRO Guideline 2022, which is sitting right beside it, I've taken all the images from the second trimester guideline. Now I ask you the question, which guideline has got more images that you require to take as part of a routine screening or a detailed examination? And the answer is there are more images in the first trimester in ISRO guidelines than there are in the second trimester. That in itself tells a story that we're in a new world of screening the first trimester beyond just measuring a nuchal translucency. We've moved into the field of anatomical screening in the first trimester. So if you say, Simon, okay, just screening for structural problems as well as Down syndrome screening and screening for preeclampsia, I think it's important to have a good understanding of what the expectations are of anomalies that you are going to pick. And I think it's good to divide them into these groups. You'll always see, sometimes see, infrequently, or it's simply not possible. Like you can't pick up migrational brain disorders in the first trimester. You can't pick up agenesis of the corpus callosum before 14 weeks. But I think it's important to understand what are the abnormalities where the expectation is that you should pick up, particularly those that are lethal, incompatible with survival. So if we run through this in a systematic approach, starting with the head, when you look at the head and the detailed assessment, we spoke today about these landmarks as we did the live scan. We spoke about this space here being the biggest space, this space here, then the next space, and this space here being the smallest, the brainstem, the intracranial translucency, and the cisterna magna. And that's something, as part of when you're taking a nuchal translucency measurement, frequently you will find these 3 black spaces are in view. And this is what the detailed ISRO guideline is now, the expectation of what you see as part of a first trimester examination of the brain. That's the sagittal imaging of the brain. And then I'll be quick on this because I demonstrated this during the live scan. The midline falx, the fluid in the lateral ventricle, the choroids, they're sometimes quite irregular, which is normal, posteriorly, and they may be asymmetrical, which is normal. And you see that the choroids should occupy more than 50% of the lateral ventricles. So compare the fluid anterior and posterior. Importantly, you can see the calvarium bone present. In fact, the calvarium bone is ossified by 10 weeks of gestation. The next you see the cavum velum interpositum, and the next you see this black fluid-filled space, which is the aqueduct of Sylvius. And then last, you see this fluid-filled space, the intracranial translucency, lined by the choroid, the echogenic bar. We do that for every scan that we do at 12 to 13 weeks of gestation. If you do those two sections on sagittal and axial imaging, you'll identify the majority of major CNS malformation in the first trimester. And they are acrania, cephaloceles, and holoprosencephaly. If you are junior in your training, you may do the scan and say, that looks to me like a baby who's got a nice thin nuchal translucency. You may decide just to take a crown rump length and say that's fine, pregnancy is normal. But for those of you in the room who are experienced will say, no, there's something not quite right about that. The baby has got acrania, but you may not spot that on a sagittal section. But if you do a 4 quad, there's no cranial bone. There's not a single landmark across the 4 sections that I mentioned about that are visible when you do this section. So almost in a 4 quad assessment, it becomes an unmistakable diagnosis. Whereas just doing a sagittal imaging, you may be so focused on the nuchal translucency, you may not recognize that the baby has got acrania. And the next abnormality, which we talk about, the Kypros Nicolaides series of over 100,000 pregnancies screened, that 100% of these, and I never like saying 100%, but 100% of these are detectable in the first trimester of pregnancy. Most of these are occipital, and I'll talk a little bit more about these in the separate talk dedicated to CNS. And this is a patient I just saw very recently at 9 weeks of gestation, and you can see there's a single anterior monoventricle, absence of the midline falx, and sharing of the choroid across the midline. A very detectable abnormality very early in pregnancy, and frequently associated with the trisomies. So these anomalies you will all pick on a 4-quadrant assessment. You may pick them up even earlier. This is a patient just I saw a few days ago, and you can see at 9 weeks and 4 days, this fetus has got acrania. You can see the hyperechogenic amniotic fluid when compared to the hypoechoic coelomic space, and this is a 3D rendered image of this 9-week embryo. When I looked at the co-twin, I could see this one had an encephalocele measuring about 8 weeks in size, but there was no heartbeat on this. So a missed AB with an encephalocele and an acrania and a co-twin in a patient who's 9 weeks and 3 days presenting for dating before drawing blood for cell-free DNA. We have reported on this even earlier, around 6 to 10 weeks of gestation, which we recognize that the abnormal shape to the cranial end of the embryo. And in the latest edition of the White Journal, you will see this picture, and it relates to this patient. So I think it's going to shift in the next few years, going to earlier and earlier in detecting these major abnormalities incompatible with survival early in the pregnancy. But I don't want to focus too much on this today. I want to stick with the big ticket items at 11 to 14 weeks. In fact, I would say 12 to 13 weeks. During the live scan, I spoke today about looking at the face on a sagittal section, the retronasal triangle, and then taking a picture of the mandible and the maxilla. And doing that split image, looking at the lip to make sure it is intact over the maxilla. I think doing that, you're going to identify the majority of clefts. In fact, Jahen Kariman from an Irish Papageorgiou's group, if you look at it, they said if you have no protocol in examining the face, you will miss all clefts in the first trimester. But if you have that segmental approach, what I showed today in the live scanning, you will detect 50% of them. In fact, I think you should be detecting a little bit higher than that if you include all orthogonal planes. So it always historically was said, Simon, you can't detect clefts in the first trimester. With the data now supports it does, but you just need a protocol. So the clefts you can pick are the very obvious bilateral clefts, or they may be the very subtle clefts. In here, you can see the maxillary gap, in this one here, and the retronasal triangle. So both on the sagittal section you can see, and the coronal section is abnormal. But the baby's lip is normal. This is not a cleft lip. This is an isolated cleft palate. Because as you sweep through it, as the face and the coronal section, you come out to the lips, and you see that the lips are normal. These are far more challenging diagnoses, but it just shows you the power of ultrasound in the first trimester of pregnancy. You may pick up also the severe micronathias or the anathias. I don't think anybody would mistake this. See a nice brainstem, fourth ventricle, nice thin nuchal translucency, but there's actually no mandible. What's far more challenging, though, is not the anathias. What's far more challenging is the retronathias. And these are a group you need to be careful about because they can be transient and you have to be cautious how you cancel them. When you look at the retronasal triangle, you see there's no associated cleft, but there is micronathia. And you asked, does 3D help? And I say, yeah, I think it does, particularly when the lip is okay and intact. And this is another case of an isolated palatal defect with an intact lip. Does 4D help? I've usually made my diagnosis on 2D, but when you look at this baby opening its mouth, you can see the cleft here. It's got a unilateral cleft lip and a cleft palate at 13 weeks of gestation. Also, with regard to the facial profile, you can recognize this very abnormal profile where you have a reduction in the frontomaxillary facial angle, in the sloping of the forehead, which you see with spina bifida, you see with encephalocele, you see with holoprosencephaly, or you can have an increase in the frontomaxillary facial angle where it becomes larger, closer to 90 degrees or more in babies with Down syndrome, or in this baby with thanatophoric dwarfism. And in terms of seeing these very early in pregnancy, I'll mention, just give one or two examples to say how I feel the direction this is going. But this is a baby with a cleft lip here at 9 weeks and 6 days of gestation. So we are seeing these even earlier in pregnancy. And this is at 10 weeks and 2 days of gestation with bilateral cataracts. Important to identify cataracts because they've got such a strong association with a genetic cause in the first trimester of pregnancy. Then with regard to the fetal neck, we spoke this morning about the importance of continuing to measure nuchal translucency. We screen for Down syndrome via cell-free DNA, but I think it's very important to continue measuring a nuchal translucency routinely in all pregnancies because it's such a powerful marker for many things beyond the aneuploidies. And the major abnormalities you will see the cystic hygromas, almost unmistakable diagnosis, but they can be challenging because it enters different diagnoses of Downs, Noonan's, and Turner's. And for these, you need to have a target assessment, particularly the cardiac anatomy, looking for either right heart or left heart lesions to distinguish between the two. When you look at this case here, when you see these gross cystic hygromas quite frequent in the first trimester, you will see there's also hydrops fetalis, and you can see an anterior abdominal wall defect of an omphalocele minor. In the setting of Noonan's, look for pulmonary stenosis. In the setting of Turner's, look for a small left ventricle. And this is an example of a baby with Turner's with hypoplasia of the left cardiac ventricle with a pleural effusion, subcutaneous edema, and a cystic hygroma. And when you look with color Doppler, again, I make the point with using power Doppler, you can see the left cardiac ventricle is much smaller when compared to the right. We're faced quite frequently with these dilated jugular lymphatic sacs. They can be challenging. For most of them that are really this size, they will also have an increased nuchal, but quite frequently you will see just jugular lymphatic sacs and a thin nuchal translucency. And these patients who have low risk NIPT and nothing else, we don't make any mention to the patient because it just causes concern and there's no evidence to suggest that they're associated with adverse outcome. With regard to examining the fetal spine can be challenging, and I would say if you look at Valdo Sepulveda's work, about 10% of the time you scan, you find that you're not able to see the spine. We do not bring patients back for re-evaluation in this setting. We recognize the spine can be challenging. We do use 3D, though, to try and reduce that rate from 10% to 5%. And why are we looking at the spine? Mainly from the point of view of looking if you see dropout in the spine when you're doing a scan at 13 weeks. You then will do a 3D volume assessment, and you can compare these two. The one on the right is normal, and the one on the left shows a baby with hemivertebrae. And why is hemivertebrae important? Well, because the association with hemivertebrae with Vactral, and I think once you see hemivertebrae, your next step is to go looking for associated abnormalities. And this is a patient I just saw a few days ago, came in for a routine first trimester scan at 13 weeks, and you can see in the lumbar sacral spine, it can look quite disturbing when you look at it in the coronal section, but the upper spine is normal, and you can see multiple hemivertebrae on a coronal section. But the only way to really understand what's going on when you see these multiple hemivertebrae is actually axial imaging and go down section by section looking for your 3 dots and find out what's happening in the vertebral body anteriorly. And you'll see, in fact, this baby only has 3 hemivertebrae, not complete disruption of the lumbar sacral spine. And you go looking for features of Vater. When you look at this baby, you can see there's aortic override. So this baby has not just got hemivertebrae, but it also has a aortic override. And therefore, this baby is likely to have either tetralogy fallow, double outlet ventricle, or common arterial trunk. But you can see the pulmonary artery is much larger when compared to the aorta. But the hemivertebrae was actually the thing that brought us to this diagnosis in this baby a few days ago. And then, of course, the spine. 30% of babies with spina bifida will pick up spinal defects. The meningeal myelocele are very straightforward. These are extremely challenging because all you see is a tiny ulcer in the skin. And so how do you pick them? Well, you pick them by looking at the head signs. And then the third group is the group with spinal dysraphism, who are generally grossly disrupted spine that you see with the trisomy 13 and trisomy 18. And then, as Asma mentioned, it's the OIES complex. And for most of these, we pick these up in the first trimester because they're very striking abnormalities, not just the spina bifida, but they also have abdominal wall defects, and also in this case, gross distortion of the fetal limbs, a diagnosis made at 13 weeks, not at 18, 20 weeks. And for many of these, as I say, at the pre-night PT scan, we're picking up the anterior abdominal wall defect at 10 weeks, the spinal defect at 10 weeks, and in fact, even earlier, and this is an 8-week embryo. The thorax, however, is challenging. I know the most common abnormality we all see in the thorax is congenital pulmonary airway malformation. We don't pick them in the first trimester. We do pick diaphragmatic hernia, though. About a third of diaphragmatic hernias we'll pick in the first trimester, and they look the same as they do at the mid-trimester. You see the stomach inside the chest, with shift of the heart into the right hemithorax, and sometimes compression of the left cardiac ventricle. These carry a much worse prognosis when compared to making a diagnosis in the third trimester of pregnancy. The perinatal mortality rate in a baby with a diaphragmatic hernia diagnosis at 13 weeks is about 61%, compared to the perinatal mortality for the first-time diagnosis in the third trimester of only 10%. So how we cancel these patients is different. And after the chest, the other abnormalities you may see is bilateral hydrothoraces, and these are usually part of a baby who's hydropic most often. Increased nuchal translucency, sometimes cystic hygroma, and this is a baby with trisomies. And for these, we can pick them up earlier. Again, I'm giving just examples of these as we go along, because I feel this is the way we're going in the future. And this is a baby with bilateral hydrothoraces, and anytime you see that, it's commonly associated with exteriorization of the heart. And this is a baby with cardiac exstrophy. If you look at the newer technologies with transparency and silhouette, you can see here the bilateral pleural effusions, and with a stick rendered image, you can see the exteriorization of the cardiac pulsation. So that's at a very early gestation. But let me not digress. These diagnoses, for the greater part, are made at 12 to 13 weeks. I have a separate talk on the heart, so I'll be quick on this one. But with regard to cardiac diagnosis, this is a scan of a patient who I saw 27 years ago, an IVF pregnancy. And when you look at the left cardiac ventricle, it's hypoplastic, a dichorionic twin gestation. And I saw the patient back again at the mid-trimester, confirming the diagnosis of a hypoplastic left heart. That's what the images looked like in 1997. That was the machine I was scanning on, but this is where we are today. The quality of the imaging that you see today allows you to visualize the heart, which begs to base only measures about 9 millimeters to 6-7 millimeters across. But as Badar said, the single most important thing in imaging in the first trimester is magnification and correct use of Doppler, as Asma sort of quizzed me on as to what the settings were in routine imaging. But if you look at the data that's just come out, that's just been published from Iris and Sheehan's group, if you have got no protocol, your detection rate of cardiac abnormalities in the first trimester is going to be 13%. And this is on huge numbers across population studies in the UK. But if you have a 4-chamber view of heart, outflow tract, using Doppler as I described this morning, your detection rate of cardiac abnormalities is 78%. That's a pretty impressive figure. In fact, that's, you would say, higher than the detection rate of the mid-trimester based on certain studies. And in fact, it becomes very relevant in Australia because we're dealing with a population of patients with large BMI, and we're really struggling with seeing the anatomy of the heart in the mid-trimester. Therefore, we're actually more reliant on what we see at the first trimester at 13 weeks than we are what we see at 18 to 20 weeks of gestation. And I will cover this separately, but we can pick up hypoplastic right hearts. We can pick up Epstein's anomaly. This baby in the bottom left-hand corner is a common arterial trunk. This one in the middle is an AV canal defect. And this one here is a monochorionic monoamniotic twin with a normal heart on this side, showing the 4-chamber and the 3-vessel tracheal view, whereas a single ventricle in this baby with a single great artery with reverse curvature. So these major abnormalities are generally very straightforward diagnosis if you stick by that protocol. You can also pick up the minor abnormalities, the right aortic arches, this baby where the ductus venosus drains directly into the IVC, and the IVC continues directly, continuing as the azygous vein, absent ductus venosus and interrupted IVC. You can pick up the aberrant right subclavian arteries and the double aortic arches. So even these subtle abnormalities we're picking up in the first trimester of pregnancy and offer invasive genetic testing. But I'll discuss these later. With regard to looking at the abdomen, the two sections, we look at the issue guidelines, the abdominal contents 1 and the abdominal wall 2. If we look at the abdominal contents, bowel obstruction looks no different in the first trimester when compared to the second or third trimester. Dilated loops of bowel, increased peristalsis, and hyperechogenic loops of bowel, particularly emphasized on 3D using VCI static. Exactly the same criteria we use to make the diagnosed second trimester, but it's just that only a small proportion actually present in the first trimester. Many, in fact, don't present in the second or third, they present after birth. In fact, many present for the first time in the third trimester. Large bowel obstruction is pretty unique in the first trimester. It presents in a bizarre way in that many have all the classic features of anorectal atresia in a patient who I saw very recently, and by the time she got to 20 weeks of gestation, she had nothing to see, completely normal. And that's a classic presentation of anorectal atresia. In fact, the only time you're going to pick it is indeed the first trimester of pregnancy. So you make a case, in a sense, for first trimester being superior than the second trimester. Then there's megacystis. This is a baby with a maximum longitudinal bladder length of more than 7 millimeters, a very borderline in this baby. And seeing that, we offer invasive genetic testing. Most of these come back normal and the bladder returns to normal. Very good prognosis. But once the bladder length is more than 15, these carry a terrible prognosis, a terrible renal prognosis, but also the problem with the secondary respiratory complications. We can pick up the more subtle abnormalities. So this is a normal kidney in the top right-hand corner. We showed that this morning. They are quite bright in the first trimester. But you can pick up duplex system. Again, these can be part of a genetic syndromes or aneuploidy. You can pick up renal agenesis, a kidney opposite on one side, and you can pick up a horseshoe kidney. And as Badar said, is you can't go home without seeing the urinary bladder, because if you don't, it's not just bladder extravy, as Asma made mention to, it's bilateral renal agenesis. And our detection rate is terrible for bilateral renal agenesis. Why? Because we're sending patients home without seeing the bladder. You have to see the bladder during a first trimester scan. With regard to the abdominal wall, the detection rates when we talk about on Kypros Nicolaides' study was 100%. Again, I don't like the figures of 100%, but they were 100%. And in a sense, I think gastroschisis may be a little bit more challenging when compared to omphalocele, particularly when the bowel loops are stuck between the baby's legs or mobile between the baby's legs. I can think it can be more challenging. But these are diagnoses anyway that are, let's say, somewhere between 90 to 100%. The expectation is the detection rate is up there. And these are just 6 cases showing babies in different positions, showing that some of them are easier to see than others. And I think also understand that we actually do offer invasive genetic testing for gastroschisis, and this is a baby with an increased nuchal translucency, which you say, well, that is an indication in its own right. But the association is actually very low, but it exists in the order of about 2 to 3%. And I think if that's 2 to 3%, you're talking a 1 in 30 chance, and therefore we do offer invasive genetic testing. With regard to omphalocele, these are very striking. I think these are much easier diagnosis. We use 3D technology to distinguish between bowel and liver. And this is the case here is a liver, which is isoechoic, and bowel, which is hyperechoic. And for most of these, very striking. Asma, I think, has written a very nice paper talking about measuring the circumference of the hernia, reference to the circumference of the abdomen, and using this as a tool to distinguish whether this is going to be a primary surgical closure, single operation repair, or multiple operation repair. The principle being the larger the omphalocele, the more likely it'll be more than one operation. And anytime you see that the liver is exteriorized, you always ask yourself the question, is there anything else out there with it? You see multiple loops of bowel, and then you ask yourself the question, where's the urinary bladder? And if all of it is exteriorized, then you're looking at a cloacal extravy. And that's a terrible diagnosis, because the surgery that's involved in repair is far more complex than making a diagnosis of just an omphalocele. Check for these and looking at the cord. I think the first trimester is a perfect time for looking at the cord and seeing cord anomalies. I made mention to this earlier on today. And for many of these babies who have this short cord syndrome, you'll find they also have scoliosis. You'll find the abnormality in the spine, and they also have very abnormal deformity positioning of the lower limbs as part of the defect. Again, I mentioned one example. In each case of each organ system, we pick these up at the pre-NIPT scan. So this is an embryo at 9 weeks and 4 days where you appreciated that that's not physiological. And this is the same patient back at 12 weeks and 2 days. We did not do NIPT for this patient. There's no point doing a screening test when you pick up a major abnormality like this. If the patient wants invasive genetic results, you go on to invasive genetic testing and you bring her back at a time when you can. You can't do a chorion biopsy at 9 weeks and 4 days. And then before I leave this is make one important point. For these tiny omphalocele minors, once you make your diagnosis of these, just be careful about it, because you may think that that's all that there is, but you need to track the bowel down the full length of the umbilical cord. And as you do, you see multiple loops of bowel extending a good distance down the cord. Why is that important? It's important because when you go to clamp the umbilical cord, if you clamp it here, you're going to basically cut off a loop of bowel. So anytime you see an omphalocele minor, you need to track through the full length of the cord. With regard to examining the fetal limbs, you need to examine all the segments, and I spoke about this morning. There are 12 segments in total. And if you look at the segments of the bones in each of these, you do a split image dividing it into two sides. Less important to do that when looking at the legs, because the legs are much easier to see, but it's easy to look at the same hand or same arm twice. Just don't make that mistake. And for most of the skeletal dysplasias you're going to see in the first trimester, it's focal. Lethal skeletal dysplasias are a really tiny percentage of what we see, and again, really tiny numbers after 30 years of practice when I make the diagnosis in the first trimester. And these are the sort of proportions we're looking at. And therefore, when I talk about skeletal anasma, we'll be talking about it, it's the focal anomalies that are far more prevalent. In fact, I would make the case that you're far more likely to pick up these focal abnormalities at 12 to 13 weeks than you are at 18 to 20 weeks. And the data supports that with high detection rates. In terms of seeing the full baby with the amniotic fluid, yes, you can see these babies with skeletal dysplasias because the hands look large in reference to the limbs. And yes, you can see it when you look with 4D evaluation. You can make a guesstimate as to what the particular skeletal dysplasia is, but ultimately it's a genetic diagnosis for many of these babies. But the point I make is, if you make the call of these skeletal dysplasias early in the pregnancy, if you see hypomineralization of the spine, if you see a cloverleaf skull, if you see any of the supporting markers that give rise to any of these skeletal dysplasias, which Asma is going to talk about, is you will have your exome sequencing result by 17 weeks of gestation, 17 to 18 weeks of gestation. Because we know for these skeletal dysplasias that the vast majority are single gene disorders. But what I spend most of my time over the last 13 years looking at is not those. It's these, the polydactylies of the hands, polydactyly of the feet, ectrodactyly of the feet, oligodactyly of the hands, oligodactyly of the hands, in which this case there's only 4 fingers, in this case there's only 3 fingers, and then oligosyndactyly, which we see in this baby here in the bottom right-hand corner. These, as a general rule, are very straightforward diagnosis in the first trimester of pregnancy. The more troubling ones are these ones, the transverse limb defects, the radial ray deformities. You can see an arm, forehand, 3 segments here, but when you split the image to update to look at the opposite side, you only see 2 segments here because the hand is missing. And this here on the right-hand side is an absent forearm in this baby, and this bottom left-hand corner is a complete absence of the upper limb, and a radial ray deformity in the middle, and another radial ray deformity here. So as we look at this here, these limb deformities, many of these are related to amniotic band. And this patient just saw a few days ago, when you look at the hand, you see it's stuck to the amniotic membranes. The only way you're going to pick these up is by increasing the gain and seeing the bands attached to the fetal hand. Otherwise, they'll go undetected. In fact, I will say where your greatest detection rate is of amniotic band is, in fact, at this stage in pregnancy. In fact, I would say 8 to 10 weeks gestation, but we're talking about anatomy at 12 to 13 weeks today. Your detection rate is going to be much higher at this gestation than any other time. So as we look at a summary of where we go with all of this is we spoke about looking at the genitalia. I mentioned today about looking at the pubic symphysis, and looking at above that point, pointing downwards is female and pointing upwards is male. But be careful about that. That's after 13 weeks of gestation. And finally, don't worry about cord cysts. Most of these disappear by the time you get to the mid-trimester. But just be careful about the abdominal wall. Just make sure there's no associated abnormality. I say don't worry about them as long as there's nothing else that goes with it. So I finish up by saying, where does this leave us today? And I think, ask the question, what difference does this talk make to you when you go to work tomorrow morning? Well, I hope the first thing is that you have a protocol, that you have sitting in your department on your wall or in your practice, that what's the biometry that you look at and what are the structures that you assess. And need to ask yourself, are you doing a first semester scan as part of the ISUR guideline as a basic scan, or actually are you doing it as a detailed scan? And assign where you sit with these protocols. So when you go to work tomorrow morning, this is you, and you will do this in 15 minutes. You will demonstrate the 4 sections of the brain. You will do a sagittal section throwing the 3 spaces. You will do a maxilla and a mandible. You will do a right and your left arm. You will look at the sagittal of the diaphragm, and you'll show a 4-chamber view of heart with a 3-vessel tracheal view. You will do that in about 10 minutes. You will proceed with the rest examination, confirming that both kidneys are present on each side. You will see there's a bladder present with 3-vessel cord. You check the stomach is present and present on the normal side. You will look at the spine and confirm that both legs are present, and then you will check the placenta, cervix, and liquor. You will do that in 15 to 20 minutes duration. And in doing so, you will reach the point where you recognize that you can identify the majority of major fetal malformation in the first trimester of pregnancy. I think whatever decision a mother takes as to what direction she goes forward with that, I think knowing that information earlier in the piece allows you to adopt a multidisciplinary approach to ensuring that you maximize delivery of where this baby should be born, who she looks after, and ensure that the engagement with the specialist, whatever the organ system malformation is involved in the prenatal care, and that you understand what the fundamentals are in the baby's genetics, because that's key in counseling the patients and what to expect when the baby's born. Thank you very much for your attention.